cancer specialists are seeing more and more uterine cancers in younger women. This was the trend in America about 5 years ago, where they started quoting higher number of uterine cancers in younger women in USA and in the developed countries. And of late, for the past 1 to 2 years, we're seeing this trend in India too. So uterine cancer is not a silent cancer. It shows itself, it presents itself, it has a long pre-cancer phase. Most of the times we pick up these women very early when they are still in stage 1. I changed my practice, 3-4 years ago when I saw a young woman with heavy periods or intermenstrual bleeding due to PCOD or hormone imbalance. I wouldn't necessarily go take a biopsy. I would put them on treatment to make them have a monthly withdrawal bleed like a COCP or a progesterone or something. But I wouldn't necessarily make it mandatory to take an endometrial biopsy. A BMI of more than 30 puts the woman at a higher risk of endometrial cancer.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
I welcome all the doctors who are joining this session. The reason to choose this topic is mainly because we cancer specialists are seeing more and more uterine cancers in younger women. Well, this was the trend in America about 5 years ago, where they started quoting higher number of uterine cancers in younger women in USA and in the developed countries. And of late, for the past 1 to 2 years, we're seeing this trend in India too, obviously suggesting that our lifestyles are mimicking more that of the Western culture. And this becomes a problem because obviously cancer is a problem, cancer in young people is a problem. And these two problems happening together, which is, say, a young woman with uterine cancer has yet to conceive or is not yet married, then it becomes a big problem. And the other thing with the uterine cancers is they are curable. They are almost always curable because women come to us early because they bleed so much. So uterine cancer is not a silent cancer. It shows itself, it presents itself, it has a long pre-cancer phase. So most of the times we pick up these women very early when they are still in stage 1. So when you pick them up early, you treat them, you cure them, but then they've lost their uterus and they have got a very long life to lead with no uterus, so they're not able to marry because obviously that becomes a big issue. They're not able to conceive. So they're living a long, normal life with a very major area of their life being severely compromised. Treating women with uterine cancers, younger women, differently. We are able to preserve their fertility. We are allowing them to become pregnant. We are allowing them to have children. And we are also allowing them to lead a normal life. And that is the new way of managing uterine cancers in younger women. And therefore, I chose this as the first topic of my talks. And to give you a little background, when someone talks to you about something, you need to know the validation. Of course, Medflix won't allow me to speak here without being. However, my background is done MBBS from Osmania. Then I went off to UK where I stayed for 19 years, where I did my post-graduation in gynecology. I did my MRCOG. Then I wanted to specialize in gynae-oncology, so then I did research. Then I did 4 years of training in gynae-oncology. Then I started working as a consultant in gynae-oncology. Then, to be with my parents, they were getting old and I was getting worried that I wasn't giving them any of my time at all. So I've been back to India for 6 years now and I'm working at Apollo Cancer Institutes as a gynae-oncologist. So this whole journey into gynae-oncology started almost 15 years ago, and I exclusively see women diagnosed with gynecological cancers. So be given the subspecialty and having such a narrow area of treatment, I see many, many, many women with uterine cancers, and of them, many are actually very young. So, moving on, talking about endometrial cancer, taking a while. Yeah, I want to do this talk thinking most of the people who are listening to me are probably MBBS doctors still young in their career, and maybe gynecologists or maybe oncologists. I'm not sure. But I just want to give a brief outline into cancers. Well, we all know cancers happen due to mutations. Mutations happen to the cells, and the mutated cells undergo mitosis. They divide in number, they increase in number, and then they become a tumor. So the basic cause of a cancer developing is a normal cell converting into a mutated cell, which then turns into a cancerous tumor. And the cause of mutations could be multifactorial or could be something like environment, pollution causing lung cancer, or lifestyle, spicy food causing stomach cancer, or chemicals. We know, say, for example, barbers are at risk of bladder cancer due to the dye that is used in hair dyes. Hormone associated cancer, say, for example, someone takes excessive hormones, they are at risk of breast cancer. An obese woman who has extra estrogen circulating in her system is at risk of endometrial cancer. So some of the cancers are hormone related. And then again, when you talk about the type of cancer, so what is the cause of cancer? Two, what is the type of cancer? Cancers are divided into adenosquamous, excluding the blood cancers. Then cancers fall into the grades. Every cancer in the body is graded into one, two, or three being a very fast growing cancer and one being a slow growing cancer. Even the rickshaw puller on the road, if he knows someone has a cancer, the thing is he's going to ask what stage. The stage is such a common word. Even a layman knows that cancer is staged. So there are four stages again to any cancer in the human body: one, two, three, and four. Four is an advanced stage, and one is an early stage where the cancer is restricted to the organ of origin. So it's a cancer of the tongue. The cancer is only on the tongue and it hasn't gone to anywhere else. And how do we diagnose cancer? It's imaging and biopsy. The biopsy could be a core biopsy, could be a wedge biopsy, could be an excisional biopsy, could be FNAC, cytology, etc. And what imaging modalities do we use to scan an organ which we think might have cancer? Then it could be ultrasound, it could be MRI, it could be CT, it could be PET CT. And each organ has a specific method of being imaged. And treatment: how do you treat cancers? We do surgery, we give radiation therapy, we do chemotherapy, we can give immunotherapy, we might use a combination. So this is about every cancer. So today, when we are talking about endometrial cancers, we'll go through this list. The cause of endometrial cancer, without a mutation in the endometrial cell, you're not going to get a cancer. So what causes mutation in the endometrial cells? Well, it's not environment. Lifestyle, yes. Chemicals, no. But hormones, yes. Estrogen is a stimulant of endometrial cancer. Endometrial cancers are always adeno. You barely ever see a squamous carcinoma in the uterus. Grade could be 1, 2, or 3. Luckily, most of the endometrial cancers are grade 1. Stage, again, it could be when the woman presents to you, but 90% of the women present to us in stage 1 or in stage 0, which is even before stage 1, because they bleed nonstop. So unless a woman is bleeding nonstop and still tends to ignore it or is so freaked out that she doesn't want to see the doctor, most of the patients are caught at stage 1. The investigations is, to begin with, we do an ultrasound scan. We prefer a transvaginal ultrasound scan because that gives a very close-up of the endometrial cavity, and the diagnosis is made on an endometrial biopsy. Treatment depends on the stage, and this is where we're going to talk about how this treatment could be different if the woman is young and wants to keep her uterus. Moving on to the next slide, which is about types. There, I'm going to keep it as simple as possible because I don't think I'm talking to gynae-oncologists here. And if any gynae-oncologist has a very more elaborate question, please do type in the chat box and we can discuss it. But endometrial cancers basically are divided into two types. So whatever you do in your career, if you come across a woman with uterine cancer, the first question you need to ask yourself is it type 1 or is it type 2? Type 1 is common, happens to 90% of women. Type 2 is uncommon. Type 1 is associated with estrogen. So the risk factors are all associated with type 1. So type 1 endometrial cancer is associated with, which is called the endometrioid type or the hormone dependent type, and it is associated with obesity, diabetes, nulliparity, anything which increases a woman's estrogen level. Type 2 is a bad luck cancer. It can happen to anybody. It can happen to the most slim woman on the planet. It can happen to somebody who had 10 kids and breastfed all of them, and it can still happen to them. So the type 2 is a danger type. It spreads very quickly. It's always grade 3. And type 2 cancer doesn't necessarily cause abnormal bleeding. So some women don't even know they have type 2 cancer unless it becomes too late. And thankfully, type 2 cancer is rare. We only see it in 10% of uterine cancers. This talk is focusing on type 1 cancer. If it is type 2 cancer, which is the danger type, then it can affect any woman of any risk factor or no risk factor. And you cannot save these women unless you treat them very drastically, in the sense, irrespective of what age or fertility status they are. Type 2 cancers should always get surgery and chemotherapy. Even though you have completely removed the cancer and it is stage 1, they still will merit chemotherapy. And sometimes we also give radiation therapy. So type 2 is a danger type, and we are not talking about type 2 today. Type 1 cancer. What is a course of endometrioid type of cancer? So we are talking about type 1 cancer, which is a hormone dependent cancer, which is also called endometrioid. So how does an endometrioid cancer develop? Well, mutation happens in the endometrial cells due to excessive estrogen stimulation. So it could be excessive estrogen or it could be deficient progesterone. Usually it is a mismatch between estrogen and progesterone. So progesterone comes from ovaries, estrogen comes from ovaries and body fat. Progesterone doesn't come from body fat. Say I have excessive body fat, then I will make estrogen from my ovaries. I will also make it from my body fat, but my progesterone is solely coming from my ovaries. So I'm going to have an imbalance of estrogen and progesterone. And therefore, the mutated endometrial cell starts to turn into a pre-invasive intraepithelial lesion, which is a stage 0 endometrioid carcinoma. And that, if left untreated, if my estrogen levels continue to be high and my progesterone levels in proportion continue to be low, then I will start to get a pre-invasive intraepithelial lesion. The pre-invasive stage 0 endometrial cancer can progress to stage 1 cancer. So endometrial intraepithelial neoplasia almost always happens before anybody gets an endometrial carcinoma. So if you could catch somebody in this stage, then they will be taken care of even before the cancer happens. How do you think a woman with an endometrial intraepithelial neoplasia happens? If you could catch somebody in stage 0, obviously that's fantastic for them, yeah? So these women are going to present with abnormal bleeding patterns, such as heavy menstrual bleeding, or bleeding in between periods, or postmenopausal bleeding. These can be the symptoms. Now, if you talk to women, how many of us actually have heavy periods? Why would we all think that it might be a precancer of the uterus? So heavy bleeding is such a common phenomenon that it occurs so commonly and so often that so many women attribute it to something they have eaten, some stress at work or some heavy work at home, or not eating properly or whatever. And so many of us ignore the heavy menstrual bleeding. We take POS-MF, we give them tranexamic acid, we give them ethamsulate, or we treat them with hormones for a while. But that is how it presents. When people have bleeding in between periods, then obviously that's a warning sign. I don't think any of us doctors will ever ignore intermenstrual bleeding. We take it quite seriously. But when it is just heavy bleeding, we might ignore it as menorrhagia. Say this woman also incidentally has a fibroid in her uterus, then we attribute it to the fibroid, or she is hypothyroid. Then you think it's hypothyroidism, which is making her menorrhagia at the early stages, or so on. So please do remember that EIN is a precancerous stage of the endometrium, which presents with heavy bleeding. And sorry. Endometrial cancer is rising in younger women. And this data is, there is no doubt that the cancer is rising in younger women because all the statistics from Europe and America, Australia, New Zealand, everything confirms the same thing, that endometrial cancer is rising in younger women. And if you think why, what are the causes of, if you think, okay, why does endometrial cancer happen to older women? What are the risk factors? The risk factors are obesity and diabetes. And also, they have had more menstrual cycles. So, a woman who has more menstrual cycles compared to a woman who has less menstrual cycles is at risk. So, obviously, nulliparous women, women who have had less number of babies, and women who have not breastfed, women with fertility issues who haven't conceived. That is because every menstrual cycle makes you have estrogen. While if you're pregnant, you're loaded with progesterone, the safe hormone, for 9 months. And at least for 6 months of breastfeeding, you're filled with progesterone. So progesterone protects the uterus, estrogen damages the uterus. So the more number of menstrual cycles a woman has, the more she's at risk of damaging the endometrium of her uterus. And therefore, obesity, one, because obesity, the fatty tissue in the body secretes estrone, which is a really bad type of estrogen hormone. And why diabetes? Mainly because diabetes and obesity are linked, and there is an unknown link between diabetes and endometrial cancer, which is something to do with insulin metabolism. And then a woman with more number of menstrual cycles, and a woman who hasn't had enough children or who hasn't breastfed enough. These same risk factors are there in younger women. So if you ask why is it more common in younger women now, or why are more younger women getting endometrial cancer, the cause is still the same: obesity, diabetes, and younger women are not conceiving until late. The risk factors are applying. It's just that younger women are becoming like older women when it comes to body habitus and lifestyle. The risk factors for endometrial cancer in younger or older women, basically in any woman, is obesity. In PCOS, what happens is women with PCOS don't menstruate often enough. A woman is meant to menstruate at least once every month. In PCOS, we do know that women sometimes don't menstruate for 2 months, 3 months, 4 months at a row, at a stretch. So, what happens to the endometrium, which is built up in the uterus? The endometrium stays back in the uterus, it stays back, and then it stays back for weeks and months, and the endometrium becomes very thick. We call it hyperplasia. And hyperplastic endometrium, it's meant to have come out weeks ago. It's only meant to be in the body for 3 to 4 weeks max, unless the woman becomes pregnant. While this non pregnant woman has kept her endometrium in her uterus for such a long time that hyperplasia starts to develop into abnormal cells, and that is called atypia, and then that turns into a cancer. So the risk factors again are early menarche, more number of menstrual cycles, delayed childbearing, and again, we talked about pregnancy and breastfeeding. So in younger women, treating becomes a challenge, and leave alone treatment, diagnosis becomes a challenge. My older women, the women who come to me with really early endometrial cancer stage 1, are older women. Because imagine if a postmenopausal woman who totally stopped bleeding starts to bleed, obviously she'll run to the doctor because she knows something is wrong. But a young girl with PCOD, or who has or hormone imbalance, or somebody with irregular periods, say her period is skipped and then she gets a very heavy period, or she's spotting on and off, or she's intermenstrually bleeding, none of us will jump to the conclusion that it could be endometrial cancer. We blame it on hormone imbalance, we blame it on PCOD, we blame it on thyroid issues, we blame it on stress at work. So it takes a long time before someone actually picks up the fact that this lady has endometrial cancer. If I look at all my under 35 endometrial cancer patients, 95% of them come to me from the fertility clinics, because these younger women have had period issues, they have had PCOD, they are not able to conceive, so they go to the fertility doctor, who at the time of assessment does an ultrasound scan or does some ovulation induction, then notices that the endometrium is very thick. Sometimes it's not even that. Sometimes the endometrium is okay. And before IVF, before the implantation these days, almost all fertility doctors do hysteroscopy and take biopsies to rule out tuberculosis. Hyderabad, where I work, this is a very common practice for doctors to do hysteroscopy, DNC, before they put the woman through IVF. And when they do the DNC, they test for microbiology, tuberculosis, and histopathology. And it is in these histopathology specimens that we see endometrial cancer, and women come to me. That is a most common route. The second common way they present is women with PCOD who have had long standing, very scanty periods. When you look at their ultrasound scan, the endometrium is 22, 23, 24 millimeters, or they have bled after 5 months continuously for the past 2 to 3 weeks when they come to me. And when I take a biopsy from their endometrium, we see endometrial cancer. This tells you that just because someone is young, do not assume she will not have a cancer. I changed my practice, 3, 4 years ago when I saw a young woman with heavy periods or intermenstrual bleeding due to PCOD or hormone imbalance. I wouldn't necessarily go take a biopsy. I would put them on treatment to make them have a monthly withdrawal bleed like a COCP or a progesterone or something. But I wouldn't necessarily make it mandatory to take an endometrial biopsy. But these days my threshold to take an endometrial biopsy in younger women is gone down. I take an endometrial biopsy when I have least suspicion, because increasingly I'm seeing more number of younger ladies with endometrial cancer. And the symptoms: abnormal vaginal bleeding. Abnormal could mean heavy periods, intermenstrual bleeding, uh, irregular with no pattern at all. And pathologically, most of these endometrioid, hormone dependent endometrial cancers are low grade. Almost 99% of them are grade 1. And like I said, luckily, most women get picked up in stage 1 because of the abnormal bleeding. And if you think, what is the worst risk factor? Say you see a young girl, she has PCOD, or she had early menarche, or she's a diabetic, or she's obese. Of all the things, what is the risk factor that really carries a bad prognosis? And that is a BMI of more than 30. A BMI of more than 30 puts the woman at a higher risk of endometrial cancer. Women with a family history of Lynch syndrome, again, are at a high risk. PCOD women, that is the biggest category. And if you think how many women in India these days have PCOD, almost 25 to 30% of younger people from, if you look at 20 to 35 age group, we see about 20 to 30% of PCOD. Young African women are at a worse risk compared to Caucasian, but in Indian context, that obviously doesn't apply. And how do you detect? The woman comes to you with abnormal vaginal bleeding, and some women get detected incidentally when they are undergoing treatment for fertility, etc. What tests would you do? Transvaginal ultrasound. These days, these days it's like I said, it's becoming easier, not easier, but I'm doing more biopsies, I'm doing more transvaginal scans, and in a way the current lifestyle of women is making it easy. At one time point, a young girl, if unmarried, was assumed to be a virgin. So taking a biopsy meant taking her to theater, and doing a transvaginal scan was almost impossible. You never do a transvaginal on a virgin. But these days, due to changed lifestyles and whatever, I don't see a virgin unmarried girl almost, I don't know. I don't know. I can't even remember when I last saw an unmarried girl who is a virgin. So, by being sexually active, it becomes easier for us doctors to do transvaginal scans and also to take biopsies without needing to take them to the theater. I'm not saying that being sexually active before marriage is a good thing or a bad thing or anything. I'm just saying that just because someone is unmarried, don't automatically assume you can't investigate them. Just check with them if they've been sexually active, and if they have, and if you need to scan them, then a transvaginal gives you a far better view of their endometrial cavity. If a woman is obese and you're not doing transvaginal and you're banking on transabdominal, you might get a false positive or a false negative. Most of the times they say we are not able to assess, so do an MRI. Instead, if you could take a proper history, and if she's eligible to do a transvaginal, do it. Sometimes you can do a transrectal scan to look at the endometrium before proceeding with an MRI. And endometrial sampling is necessary if you are suspecting an endometrial cancer. And don't think that the woman should be more than 45 for her to be able to have a biopsy. Anybody of any age group, if you think they might have an endometrial cancer, if possible, do the biopsy in the clinic by giving them good pain relief. If not possible, take them to theater. I personally think a biopsy is a diagnostic procedure. To do a diagnostic procedure, if you subject the woman to general anesthesia and a hysteroscopy DNC, you have already added the cost of your treatment significantly before even starting the treatment. So personally, I do not do hysteroscopy and DNC. I take an outpatient biopsy. The only time I do hysteroscopy and directed biopsies is when I see a polyp in the uterus. Even then, we try to do outpatient hysteroscopy when the patient is awake by using a far slimmer hysteroscope. Just to diagnose somebody, giving them general anesthesia and making them pay a bill of 50, 60,000. I've almost never done that, because in UK, where I trained and where I worked, we do outpatient hysteroscopy and we do outpatient biopsies. If somebody requires general anesthesia, that's not for diagnostic purposes, that's for therapeutic purposes. But obviously, practices vary, and if where you work, you can't do OP hysteroscopy, you can do inpatient. But most of the times, to diagnose endometrial cancer, to take an endometrial biopsy, you don't need to put the woman under general anesthesia. You can do that in the OP clinic with good pain relief. How does endometrial hyperplasia associate with endometrial cancer? Could you be like, if you see in this diagram, you see step 1 is a simple hyperplasia. So this is a woman who has a little bit of extra estrogen. And the simple hyperplasia, if left untreated, becomes complex hyperplasia, but there is no atypia. So even at this stage, most of the women are rescuable. So if you take a biopsy from all women who are bleeding heavily, so many of them will have simple and complex hyperplasia. So simple and complex hyperplasia never worry me. That is a very common diagnosis. This is what happens to women who have menorrhagia, unless the menorrhagia is because of a very large fibroid uterus or a polyp in the uterus or adenomyosis. So a woman with a normal sized uterus at the age of perimenopause is bleeding very heavily. Most of the times, if you take a biopsy, your diagnosis will be HPE, will be simple or complex hyperplasia. A woman who has had complex hyperplasia, say for the past 6 months, she's continuously bleeding heavily. The complex hyperplasia could turn into atypia. So that's complex hyperplasia with atypia. Once you are on this step, you very easily convert that into endometrial carcinoma. So people come to me with simple hyperplasia and they say, oh my God, do I have a cancer? Am I going to get a cancer? Should I have a hysterectomy? I tell them no. Simple and complex hyperplasia, when there is no atypia, you can reverse them to normalcy by giving them progesterones. And I also tell people that when you have simple or complex hyperplasia, but there's no atypia, you have plenty of time to reverse back to normal. We can send you back to normalcy by giving you oral or intrauterine progesterones. They don't need a hysterectomy. They can become normal by just giving them progesterone. It's only when people get atypia or endometrial cancer that we recommend surgical treatment. Okay, so simple hyperplasia will never jump to endometrial cancer. Complex hyperplasia without atypia will not jump to endometrial cancer. It will become atypia before which, only after which it becomes a cancer. So from simple to become cancer, a person will almost need up to 2 years. So there's plenty of time for you to catch these people and treat them with progesterones, and you can avoid them from getting a cancer. So WHO in 2014, about 10 years ago, said, don't call simple or complex. That's confusing. Instead, just say hyperplasia with atypia or without atypia. The without atypia, nothing to worry about, give them progesterones. The with atypia are at a very high risk of cancer, so treat them surgically. That is what WHO said. And how do you treat endometrial hyperplasia? It could be simple or it could be complex. And I've just told you we should not use those words. We should use with atypia or without atypia. You have two options, progesterone therapy and hysterectomy. So which do you choose for whom? You need to be very clear in your head. When a woman comes with excessive bleeding, find out if they have hyperplasia. If they have hyperplasia, is it with atypia or is it without atypia? If they have cancer, is it type 1 endometrioid or is it type 2 serous? Type 2 serous, straight to oncology. Type 1 endometrioid carcinoma, if the woman is young, then you have few options which we're going to discuss. So, treatment of hyperplasia, no atypia. So, the patient will ask you, so you're telling me I have something wrong with my uterus? What is the chance this will become a cancer? This is where most of the doctors make mistakes because they think hyperplasia means cancer. Hyperplasia does not mean cancer. Hyperplasia with no atypia, only less than 3% of them actually get cancer. The rest of them do not get cancer. But how do they not get cancer? Either the problem goes away in the sense the heavy bleeding stops and they automatically get better, or you treat them with oral or intrauterine progesterones. So hyperplasia with no atypia, you can treat them with progesterones. You can give the progesterones orally or intrauterine. Now I'm saying, okay, give them progesterones. Say you see a 35-year-old lady, large BMI, her periods are heavy, endometrial thickness on transvaginal scan. So you took a biopsy and it came back as hyperplasia, no atypia. You have reassured the woman that, look, you don't have cancer. Less than 3% of women at your stage will get cancer. The 97% of you will be fine. So let's treat you with oral progesterones. How long will you treat her? She's 35. And you think the risk factor in her case is obesity. So how long will you treat her and how long should you treat her? Will you treat her for 3 months, 6 months, 12 months? Any treatment should stop at some time point. Yeah, you can't treat people forever. So this woman will say, okay, I'll take progesterone. How long do you want me to take it? Well, the answer is difficult because the risk factor is obesity. How long will she be obese? How long do you think she'll be obese? Or if you say, look, your obesity is the cause of this problem, you have to become slim if you want this problem to go away. How long do you think this woman is going to need to become slim? And where is the guarantee that she won't become obese again? So this is a tricky bit. This is why we say treat them until the risk factor is gone. But obesity, diabetes, PCOD, when do they go away? And then they can come back. Yeah, how long will this woman maintain a strict diet and stay slim? How many women can be like that? So this is a difficult thing. And therefore, my suggestion and my advice is when you're treating women with hyperplasia and no atypia, you're giving them progesterones. Unless the woman wants to conceive, give them progesterones intrauterine. The oral progesterones have to be taken by mouth. They need to take a break to get a bleed every month. While intrauterine progesterone, I don't know if you know, but there are 2 or 3 intrauterine progesterone devices. If you put them in the uterus, each device will work for 5 years. So for 5 years, she'll keep getting progesterone. The only thing is for those 5 years, she won't be able to conceive if she conceive, but otherwise it's going to protect her from the hyperplasia. Yeah, this is what we already discussed. Most of these young people are obese and nulliparous or infertile. They go to fertility centers and that's where the doctor picks up their hyperplasia. Now we are moving on to hyperplasia with atypia. So this is where the endometrium is not just thick, but it's also abnormal. Now, if you ask yourself, what percent of these women will develop a cancer, or do they already have a cancer in the deeper layers of the endometrium? That's 50%. So if a woman with atypia comes, she's like a ticking time bomb. She's somebody who already probably has a small cancer in the uterus or is going to get one very soon. How can you leave this woman alone? How can you ask her to slim down and cut down her sugars and blah, blah, get her diabetes done? You can't. Yeah? So this is a woman who you will say you already probably have a cancer or you're going to get a cancer very, very soon. There are atypical cells in your endometrium, so let's do a hysterectomy. We don't need to remove the ovaries. If the woman is young, then we only remove the uterus, but we recommend a hysterectomy, which is removal of the uterus and conserve the ovaries if the woman is young. Now, what if this woman with hyperplasia with atypia, who has a 50% risk of endometrial cancer, wants to conceive? Because she was picked up at the fertility clinic here, she obviously went there to conceive. If she finished a family or she didn't want children, she wouldn't have gone there in the first place. So she obviously is very desperate for children and she wants a child, and this is happening. So, what do you do with her? And this is not an uncommon scenario. I don't know if any of you have been in this situation, but if you speak to fertility doctors, if you speak to oncologists, if you speak to gynae-oncologists, this is an everyday scenario for us. And therefore, a woman with atypia who is a very high risk of endometrial cancer, if she wants to conceive, you can treat them with progesterones. So it is possible. It is not something me, Dr. Sai, has come up with. There are college guidelines, Royal College of England, RCOG guidelines, ACOG guidelines, Australian guidelines, you have European guidelines, every single guideline which will tell you that women with early, even if the diagnosis is endometrioid carcinoma grade 1, stage 1A, or endometrial hyperplasia with atypia, you can treat them with progesterones. Okay, there are so many ifs, there are so many buts, but you can do it. And this is what we've been doing. We've been following their protocol and we've been doing this. If I may ask, if you are familiar with this category of patients, what was the youngest woman you have seen? A youngest woman with PCOD with cancer in the uterus. You think, why did this doctor choose such a rare topic? Who does it happen to? How frequently does this happen? Now, why is she even talking about something so rare? You should talk about common things. What's the point in talking about very rare things? But it is not rare. Trust me, what day is it today? Friday. This week, I've already seen five patients, young patients from fertility clinics with endometrial cancer, one of them with hyperplasia and atypia, all of them desperately keen to conceive. And if I think about it, what was the youngest person I saw? The youngest was 22. This was in April. This girl came to me from a very small village in Andhra Pradesh. She got married at 18. She's very slim. She's very slim with PCOD because she gets very infrequent periods. And because she's been married for such a long time, a very small, very, very innocent farming family. And PCOD, 4 years of marriage, only 22, but they were worried that she's not conceiving. So they brought her to a fertility clinic in Hyderabad. Hysteroscopy, DNC, TB negative, endometrial carcinoma positive. MRI shows that it's limited to the lining of the uterus. Very hard to believe that in such a slim, pretty girl, who had very infrequent periods, this is the diagnosis. It was extremely hard convincing the family to opt for conservative management because for them it's very difficult to understand. Cancer means cancer. Cancer means you need to surgery. So they went to 3 different cancer centers in Hyderabad, obviously panicking, and 2 of them said do a hysterectomy. But she's stage 1A, stage grade 1. She's endometrioid type. She's a known PCOD candidate. So I felt there was absolutely no need to remove the uterus as long as she's responding to progesterones. There's nothing wrong in trying. If she doesn't respond to progesterones, you can always do the hysterectomy at a later date. Progesterones will rescue that uterus, and progesterones will also enable her to conceive. So what we did to her, like we do with everyone else, is I sent her to the fertility doctor. I asked them to retrieve oocytes. In 15 days, they stimulated her, they retrieved 8 oocytes, and then later they can process them into embryos with the husband's sperm. Then I started her treatment with intrauterine and oral progesterones. I'm yet to see her because I see them once every 3 months. I haven't yet seen her, but she's not bleeding at all. So I know that she's doing well. If she's not doing well, she would be bleeding by now. So RCOG, I've taken the RCOG protocol given my degrees are from UK, so I tend to follow UK protocols. And RCOG protocol says hyperplasia with atypia or stage 1A grade 1 endometrioid carcinomas. The protocol says insert Mirena, do a DNC, clean the uterus thoroughly. This is not the time when we do outpatient biopsies. We might do the outpatient biopsy for diagnosis, but when I start the treatment with medication, I go to a TNC, I completely do a hysteroscopy, completely clean the uterus out, don't leave any carcinomatous tissue. Insert Mirena. Mirena is a trade name for intrauterine progesterone. This is an American product, and this is the only product I've been using. I haven't used any Indian products because the price is the same, and this is what I've been used to for the past nearly 15 years. So we insert an intrauterine progesterone called Mirena. Then every 3 months we scan them, and every time we notice the endometrium is more than 6 mm, we keep the Mirena, we keep the intrauterine progesterone device as it is and take a biopsy. And if 2 consecutive biopsies are negative, that is when this woman would be advised to go for IVF. We don't allow natural conception because, as you know, natural conception can take a long time. And if you're not treating this woman, you have treated them, you stop the progesterone, because with high dose progesterone, women can't conceive. The endometrium will be very thin. So if you want them to conceive, you need to stop the progesterone. If you stop the progesterone and you have left them a long time without progesterone, the endometrial hyperplasia could come back. So what we aim for is for the first 3 months, we do nothing. We continue with the treatment. Month 6 and month 9, we take biopsies. If these 2 biopsies are normal, most of the times they are, then we remove the intrauterine progesterone device. We give them 2 to 3 weeks time, and then we advise them to go for IVF pregnancy. And after the pregnancy, we actually advise them to get the uterus removed, because whatever was the cause of mutation originally will continue to be there. It could be obesity, it could be diabetes, it could be Lynch syndrome, it could be anything. So a woman who once gets endometrial cancer is at risk of endometrial cancer again. We should have removed that uterus in the first place. We kept it in and treated it with progesterone so this woman can conceive. So once she has had her baby, the advice is actually to go remove the uterus unless the risk factors have gone. If the woman wants another baby, then until she is ready for another baby, we continue with the intrauterine progesterone. We don't leave them alone without any treatment. And compared to oral progesterones, the systemic levels of intrauterine device, sorry, you say you could treat somebody with oral progesterones or you could treat somebody with intrauterine progesterone. With oral progesterones, obviously the systemic levels of progesterone are high because you're taking a tablet. Yeah, obviously it's going to circulate in the rest of your body. And what does progesterone do to women? Say, fine, I'm giving her a high dose progesterone. I want to treat her cancer. I want to help her become pregnant. By putting her on high dose oral progesterone, what could I be doing to her? Well, oral progesterone doesn't have any serious side effects, but it can cause headaches, it can cause breast pain, it can cause abdominal bloating. And these are the side effects most women complain. When compared to the intrauterine progesterone device, the progesterone is circulating in the uterus, but it doesn't cross the uterine barrier. And therefore, there's barely any progesterone in the systemic circulation, and therefore very less side effects. So the Mirena intrauterine system, the intrauterine progesterone device, you can use it for cancer prevention. In the sense, say you come across an obese woman or a diabetic woman or a woman who has completed her family, she tends to have heavy periods, and you have taken a biopsy and there is nothing wrong, the biopsy is normal. Or you have done an ultrasound scan and the ultrasound scan doesn't show you an endometrial thickness, which is worrying. But you think, yes, this woman is obese, or this woman had PCOD, or this woman never had a child and she's at risk of uterine cancer. Is there anything wrong in inserting a Mirena to prevent an endometrial cancer? Absolutely nothing. We do that more and more. Once someone already has hyperplasia and atypia or endometrioid cancer, you can still use the device to treat the endometrial cancer. If someone has heavy periods, they don't have cancer, they don't have hyperplasia, can you use the Mirena to treat their heavy periods? Yes, you can. This is my most favorite way of treating heavy periods in someone who is not keen to conceive immediately. But what was the Mirena intrauterine system actually devised for? What was it designed? Why did it come by? Why was it ever manufactured? It was manufactured for contraception. So instead of copper T, which caused menorrhagia, they came up with intrauterine progesterone device, which is an extremely competent contraceptive, which also lowers heavy bleeding. And as a contraceptive, it works for 7 years. But they have noticed that in women who are using Mirena for contraception, there is no thickening of the endometrium, there is no hyperplasia, there is no menorrhagia. Automatically, there is no endometrioid cancer. So we use the same strategy for cancer prevention and also to treat early cancers. You might prefer to use oral progesterones, which is just like intrauterine progesterone, because even the oral progesterone eventually will go into the uterus here. So fine, if you want to use it, use it. There's absolutely nothing wrong. But studies have clearly shown that intrauterine progesterone works better on the uterus compared to oral progesterone. Because if you think about it, oral progesterones need to be taken twice daily. They are expensive. What if the woman forgets to take a tablet? What if the woman takes it late or doesn't take it on time? Then you see this up and down curve where the hormone levels have gone up, and then the next time they're meant to go up, the woman has forgotten to take the tablet. Or what is there's a gap in between the tablets. While with intrauterine progesterone, you get a very steady level of hormone, no ups, no downs, no forgetting, no taking it late, etc. So the intrauterine systems work far better. And yeah. Now look at the cost factor. If I treated, say I told you I saw a 22-year-old in April. Now this week I've seen 5 people. I have inserted Mirena in all of them. In those who have cancer on the biopsy, I've also put them on oral progesterone for 3 months. Usually the first 3 months we do both. And then after the 3-month biopsy, when I know that the cancer is gone and the biopsy is normal, I stop the oral and just continue with the intrauterine. If you put somebody on oral, they are spending about 75, it's almost 200, 160 to 200 rupees per day. While if you insert the Mirena, it is 3 rupees per day. So you see the difference. It's tremendously difference in the price. And how many Indian women do you think will be provided with medication which costs 200, 150 to 200 rupees per day? Most of these women, if they are not earning a salary, they'll depend on somebody to buy these medicines for them. Even that is a problem. When you prescribe expensive medication, you also need to think, are they able to, at the beginning, out of Josh and whatever, they're like, okay, we'll buy it. They buy it for 20 days, 30 days. They need to take it for 9 months to 1 year. How many people do you think can actually afford 200 rupees a day on medicines for 9 months to 1 year? So even the cost factor needs to be taken into account. So the cost of Mirena in India is heavily subsidized. Like I told you, it's an American product. This slide is old actually. $1,100 is equal to 1 lakh rupees now, because $1 is equal to 88 rupees. And in UK it is subsidized. In India it's even more subsidized, while people in America buy it for 1 lakh. So we Indians are lucky, we're getting it for a very small price because it reduces cancers. So how does this work? Once the intrauterine progesterone is inserted, it releases progesterone continuously into the intrauterine cavity, and the endometrium becomes very thin, and the hyperplasia goes away, and the endometrial cancer also resolves, because it is a progesterone. It is an estrogen-induced cancer. Inserting high-dose progesterone into the tissue will make the endometrium thin and the cancer will disappear. And how do you test? We do an ultrasound for endometrial thickness. We do an endometrial biopsy. Before you do surgery, or before you treat them with intrauterine and oral progesterones, you need to be 100% sure that you're doing no harm to the woman. you want to do something good, but in the long term it shouldn't turn out that you're doing more harm. So make sure that the disease is only in the endometrium. The disease should not be in the myometrium. The disease should not be in the pelvic lymph nodes. The disease should not cross the endometrial cavity. So it's very important to do an MRI. MRI gives you a very good cross-sectional image of the uterus, which will tell you if it is a stage 1A or stage 1B. PET CT is not usually recommended. PET-CT is to detect distant metastasis. If the disease is stage 1A, how are you going to get distant metastasis? Yeah, common sense. So, bottom line, can the uterus be spared in uterine cancer? Yes, of course it can. And even like yesterday, when a patient came to see me, she went to a really good, a very reputable institute in Hyderabad, a cancer institute, where they said, you need your uterus removed. And then she told them that her cousin in USA had a similar issue and she did not have her uterus removed. Then this doctor from a trust hospital in Hyderabad said, okay, yes, there is one way of treating, but that means you take lots of medicines. You need to be seen multiple times. We in the trust hospital don't have that kind of time for you, but you can go to Dr. Apollo and Dr. Sai is there. She can help you. That's how she came to me. So many doctors are aware that you could actually treat people with oral progesterones or intrauterine progesterones. You can help them get pregnant, but it is a significant hand holding. The number of times you have to see them, reassure them, do scans, take biopsies, and send them to the fertility clinic at the end. So it's a lot of work compared to just doing a hysterectomy and discharging them or whatever, or keeping them under follow-up for cancer. So so yes, this is hard work, but it's worth it, and it is doable. But before you do it, you need to be sure that you're doing it for the right reasons, and you need your treatment protocol endorsed by a gynae-oncologist. We treat them with MPA or Megace, or with LNG IUS, which is also called Mirena. I've listed the medicines here. Not that I'm expecting you to straight away start prescribing. I've also put the cost of different medicines here. And sorry, we're going through the same thing. This is a case. This is a lady who had endometrial cancer. I treated her with intrauterine progesterone. After 12 months of treatment, when her biopsies were negative, I sent her back to her fertility doctor for IVF. Unfortunately, 2 consecutive IVFs failed. She became very depressed. She did not come back to me. She did not go back to her fertility doctor. She took a 2-year break without any treatment. This is somebody who had cancer, who had treatment, who had failed IVFs, and then for 2 years she does nothing. Then she comes back to me because she's bleeding very heavily again. Of course, the endometrial cancer recurred. This is her hysteroscopy picture. And now she says, she has 2 more embryos frozen. She had 4 embryos frozen. She used 2. They both were wasted. She has 2 more. So can I treat her for 1 more year now? And can she go for IVF? And this is a case, where you feel like they're squeezing your heart and they're bombing your head, and you think, no, you should have come back to me when your IVF failed. Your cancer had come back, and then you wait for 2 years, and then you come to me. Well, they twist you in such a way. And then so I reassess her, I redo her biopsy, I redo the DNC, I redo the MRI, and now it is stage 1A, grade 1 endometrioid. So technically, yes, she is eligible for treatment. So after taking all the consents, we treat her again. So I put the Mirena in, I give her oral progesterones. After 9 months, biopsies are negative. She goes back for IVF. This time I make her promise that she will come back if the IVF fails. She won't just sit at home. But see what happens. This is her. Sent me a WhatsApp message when the twins turned whatever, 1, or I can't remember. And she got twin girls with her IVF, but she didn't come back to me. So the twin girls were born. This message basically reads, my girls are one thanks to you. Without you, I wouldn't have had the twins, and blah, blah, and blah. I'm starting to bleed heavily again. What should I do? It's not a surprise she's bleeding heavily again. The twins are one. She's resumed her periods. Her hyperplasia with ATP or the cancer has come back. After the twins were born, we did tell, look, second time, third time, don't take a chance. This cancer will come back. Most of the times it will come back. So please come back, get that hysterectomy done. She didn't, obviously, But around a year after the twins were born, she messages me to say, "Thanks so much, but I'm bleeding heavily. What should I do?" And we put a Marina, and she was so reluctant to have a hysterectomy. She said, I have twin girls, 1 year old. How do you expect me to have major surgery? Then I said, fine, don't have major surgery, have a DNC and have a Marina. And when you're ready, have surgery. But take some treatment. Leaving you alone without treatment is not an option. We're reaching the end of the talk. These girls who are at high risk of endometrial cancer at a young age, they're also at a high risk of ovarian cancer. So that is something you need to keep an eye on. You need to regularly scan them. And these days, for endometrial cancer in younger women, the recommendation is don't remove the ovaries, don't make them menopausal. They're already had one cancer. Now, if they are menopausal at a very early age, they are at a high risk of heart disease and osteoporotic fractures. So they advise us to keep the ovaries, but they're at a higher risk of ovarian cancer. So you also have to be sure that you're regularly monitoring their ovaries by transvaginal ultrasound scan. However, these young women with endometrial cancer, whichever way you treat them with intrauterine progesterones or you treat them with a hysterectomy after they conceive, they have a very, very good prognosis. So my request, my take-home message to each and every one of you out there is this cancer is on the rise in younger women. In your doctor career, you will eventually come across some woman who has endometrial cancer and who still wants to conceive. And if you do a hysterectomy even before you gave her a chance to conceive, you have taken that opportunity away from her for the rest of her life. Though she will live to be a normal 70, 80-year old, like her friends and colleagues and relatives, she will not be able to marry, or even if she marries, she'll not be able to conceive, which will remain as a major depressing issue in her lifetime. So please, if you come across a woman with endometrial cancer, discuss with a gynae-oncologist, see if there is any way we can help her to get pregnant. If not immediately, so many of my patients are not even married, they don't even want a child. They've been picked up in the PCOD pathway. So for them, what we do is we put the Mirena in and we don't remove it until they are ready for conception. So there are ways we can protect and help these women. So please do consider it. Don't think cancer means surgery. Cancer doesn't always mean surgery. We can conservatively treat certain type of cancers and we can help these people lead as normal a life as possible. I'm open for questions.
Thank you, ma'am, for that very interesting talk. We do have some doubts coming from our doctors, ma'am. I'm taking one of the earlier questions that we had. It is also highlighted on your screen now.
Mhm.
So, Dr. Madhav Kulkarni is asking, could endometriosis be a pre-malignant lesion?
Endometriosis is not a pre-malignant lesion because not all endometriosis turn into cancers, but endometriotic lesions can in future turn into endometrioid carcinomas. Because endometriosis is not in the uterus, yeah, it's outside the uterus. So when you see endometrioid malignancy of the ovary, that is usually due to endometriosis. So clear cell and endometrioid carcinomas of the ovary are due to endometriosis, but we can't say endometriosis is a pre-malignant lesion because very small number of them actually turn into cancer. Majority of them don't.
Right, ma'am. So, moving on to the next question. So, it is from Dr. Ravindra. What is the ideal biomarker to diagnose endometrial malignancy at the earliest stage?
There is no biomarker actually. There is nothing you could check in the blood to find out if someone has endometrial cancer. Various biomarkers have been proposed like P10 and whatever, but none of them have been proven useful. So there is no blood biomarker at all. Even in the advanced stage, you can't do a blood test to tell how advanced somebody's cancer is. Like for ovary, you do CA1 to 5, but for endometrial cancer, there's nothing. But good thing is these people come. They come to you with bleeding. That is the way we find out endometrial cancers.
Next is from Dr. Kajal. Can a slim girl also get endometrial cancer, and what is the percentage?
Slim people can also get endometrial cancer. Slim people can also get endometrioid, the most common type of endometrial cancer, which is thought to be due to diabetes and obesity. So it's like, slim people have PCOD. PCOD is meant to be associated with obesity, but we see so many slim PCOD patients. So, yes, slim people can also get endometrioid cancer. I have seen so many African ladies who have had 13 babies, 14 babies. It's very common for African ladies to have a lot of babies, and they are coming with endometrial cancer. And you think, hang on, what's happening? We always thought having too many children protects you from uterine cancer. But these days, nothing seems to be stopping people from getting cancer of the uterus, even the endometrioid type.
So next from Dr. Mohiddin, does every patient of PCOD need follow-up for evaluation as you quite often see such cases?
Look, PCOD patients, we say they need to menstruate at least once every 3 months. Or every woman, if you don't want her to get uterine cancer, should have minimum 4 menstrual periods in a year, 4 to 5. So every 3 to 4 months, the woman should menstruate. So we don't necessarily keep the PCOD patients on follow-up, because how many people can you keep on follow-up? There's so many of them. But what we tell them is, say after they don't want to use COCP, they don't want to get monthly bleeds, because COCP again, you put them on medication and they have headaches or nausea. Some people don't like it because of the water retention, migraine, etc. So we tell them wait for 2 months, max 2.5. I actually ask them to take a progesterone for withdrawal bleed. So every 6 weeks, you wait for a month, your period didn't come. Take 2 more weeks, exercise, eat papaya, pineapple, sesame seeds, the natural prostaglandins, and still your period didn't come. Then take 5 days of progesterone and make yourself bleed. In students who don't want to do that, I ask them the maximum they can wait is 2 to 2.5 months. The period didn't come. Take progesterone, make yourself have a withdrawal bleed. So it's when people bleed very frequently, they bleed for 10, 15 days, spot for 10, 15 days a month, or they have more bleeding than what you expect in a PCOD. That is when I ask them to come and see me again. So I leave the follow up with them, because following up every PCOD patient becomes very difficult, because these are young people, students, they travel a lot, they change places, etc.
Ma'am, next Dr. Kamble is saying that if a patient's family is complete, then what can be the use of keeping uterus in case of cancer?
In case of cancer, no, we never keep the uterus after the family is complete. Look, every single time we have been using intrauterine and oral progesterone, the only reason is to help them conceive. So we never actually want them to keep their uterus afterwards. We want to remove it. We insist on removing it. It's just patients don't come back to us. Once the purpose is solved and there's a baby in your arms, they forget about this doctor who treated you for cancer and who wants you to have a hysterectomy. They don't come for follow up. They don't answer our phone calls. It's them who are not coming back for uterus removal. We want to remove the uterus. You should remove the uterus.
Another question from Dr. Madhav was when endometrial fulguration is indicated?
Sorry? Fulguration.
When? Yes. Yes, ma'am.
Sorry, I don't understand. Why would anybody fulgurate anybody's endometrium? Endometrial fulguration. No, we have resected endometriums, but a microwave ablation I have heard of. Fulguration I've never heard of, actually. Even the microwave ablation, we don't recommend it, because it's leading to a lot of adenomyosis few years later. So even the microwave ablation these days is not recommended. It's an abandoned procedure in most developed countries.
Next
You
question
mean
from Dr. Rashad. Yeah,
if
ma'am.
you mean transcervical resection of endometrium, which is not fulguration but resection, you resect the endometrium and then you send those pieces to the lab. We do it when we are suspecting hyperplasia or a polyp, or you want to resect a submucous fibroid, then we do that.
Next question from Dr. Vrashali is can high dose of progesterone affect pregnancy or the fetus?
Look, with high dose progesterone, you can't actually become pregnant. Your endometrium will be 2 mm, 3 mm, so there won't be any implantation. So, high dose progesterone treatment, whilst on high dose progesterone, people don't conceive at all. It thins the endometrium significantly. And progesterone per se is so full of, pregnancy per se is so full of progesterone. Isn't a pregnant woman having thousands of millimoles of progesterone in her body? So when you are on high dose progesterone, you can't conceive. But once the high dose progesterone is stopped, the effect goes off. Within 2 months, a woman starts to menstruate. So most of the times, the effect of high dose progesterone is only short lasting. And that is why these women, if you don't immediately make them pregnant by IVF, the risk of the cancer or hyperplasia coming back is so high, because once the estrogen starts again and the endometrium thickens, the whole thing can go back and become diseased again.
Next, Dr. Banerjee is asking, ma'am, what about the BRCA screening for these women?
This BRCA is not associated with endometrial cancer. It's associated with the ovarian and breast cancer. The only hereditary cancer gene which is associated with endometrial cancer is Lynch syndrome. So we check for Lynch. If someone at a very young age got endometrial cancer, we check them for Lynch syndrome, not for BRCA.
Next, Dr. Sarda is asking, does lean PCOS or obese PCOS have different risk for carcinoma?
No, no, it's not. It's not lean or obese PCOS. It's the interval between periods. If the woman has had long periods of amenorrhea, then she's at risk. But obese women have extra risk, obviously.
Next, Dr. Agrawal is asking, in a symptomless postmenopausal women, endometrium is 5.8 mm with some fluid, with a small fibroid and a small nebotian cyst. How do we manage?
Look, textbooks say anything more than 5, you need to take an endometrial biopsy. So, in such a context, I would take an outpatient PIPL biopsy, because I'd ask my sonologist if the thickness is uniform or if it's polypoidal. If it's polypoidal, then hysteroscopy and directed biopsy. If it is uniform thickness, then I'll do an outpatient PIPL sampling. To my knowledge, when the woman has no bleeding, the chances of she having a cancer in the uterus is very small. Very, very small. In fact, until 2, 3 years ago, I thought if a woman has thickened endometrium, postmenopausal woman, but no bleeding, it is incidental, it won't be anything. But in that year, I saw 2 women who had absolutely not even a drop of blood, endometrium 6 mm, 7 mm, picked up on health checkup scans. Did a biopsy thinking nothing will come out because this woman never had any bleeding, and both of them turned out to be cancer stage 1B. So, very occasionally, postmenopausal women with a small thickening of the endometrium could have a cancer and they might never have bleeding, but very, very unusual, but it can happen. So, any endometrium more than 5, I mean, Nabatean follicle is benign, fibroid is benign, that shouldn't make any difference to how you're managing. But because this is more than 5, I think it's important that you take a biopsy and prove that there is no cancer before you leave this woman alone. And obviously, you will scan her every 6 months, at least for the next 2 years.
Next from Dr. Krishna Priya. Thank you, ma'am, for a very insightful session. Taking Primulid and frequently to postpone periods, does it have a risk for cancer endometrium?
Not at all, because Primulid is progesterone. Any progesterone you give anybody, it will never hurt them in any way. Progesterone cannot harm people. The progesterone only has some effect on the heart, that too in postmenopausal women. But Primulid to postpone, Primulid or any progesterone to postpone or induce a bleed because they haven't had a bleed will not do any harm to endometrium in any possible way. Progesterone is a very safe hormone.
Next from Dr. Hema. Ma'am, for endometriosis complexes, what is the best treatment for size 5 to 6 centimeter and bilateral?
Look, previously the book said anything more than 4 endometrioma on the ovary operate because they won't shrink with medicines. And then the recent ESHRE guidelines increased that size criteria to 7. They are saying if it is up to 7, you can still treat them with medication. And it also depends on, is this woman personally anything more than 4 bilateral, I would recommend surgery followed by medical management. And But if the woman is not able to have surgery, or for whatever reason you're not able to operate, financial reasons or other reasons, personal reasons, then you can treat them with medication and keep them on close eye. But if she wants fertility, then obviously she needs surgery, because bilateral ovarian endometrium is so big, how is she ever going to conceive otherwise?
Ma'am, we have around 3 to 4 remaining questions. Would you like to take them now?
Yeah, yeah.
Yeah. So next, Dr. Swami says, ma'am, these days many women complain of adverse reactions like severe vomiting and extreme tiredness. What supportive drugs can be added?
Look, it depends on for tiredness. Personally, I feel it's vitamin D and B12 deficiency. A lot of women are deficient. So these days, doing a vitamin check has become mandatory for anyone who is feeling suboptimal, and a hemoglobin and thyroid. What was the other one? Sorry, you said tiredness and.
And severe vomiting and extreme tiredness.
Look, severe vomiting, I really don't. I don't have many women complaining of severe vomiting.
Next, Dr. Agarwal says, ma'am, what type of anesthesia is used in outer endometrial biopsy?
In outpatient, nothing. That's why it's an OP clinic. Outpatient clinic, we don't use any anesthesia. We use a 4
Next,
millimeter
yeah.
hysteroscope, so no anesthesia is needed.
Next, Dr. Purohit says, dose and duration of oral progesterone in endometrial hyperplasia without atypia, and can we treat with only oral progesterone?
Yes, you can only treat with oral progesterones, Provera, 10 milligrams twice daily or 20 milligrams per day. But again, like I mentioned, for how long? How long is the problem? It's not like a 3 month course or a 6 month course. If the woman is obese or diabetic or PCOD, giving 3 months or 6 months is not enough, because she'll continue to be obese or diabetic or PCOD. So, because there is no upper limit, it's a lifestyle disease, and lifestyle diseases don't just go away, or they go and they come back. That's why giving them orally means eventually you will end up giving so many oral courses, or both of you will be fed up and end up in a hysterectomy. So, even for simple hypoplasia, if you don't think the woman is going to change her lifestyle and dramatically make changes, insert an intrauterine, so there is no worry about how long. But the dosage is 10 milligrams twice daily for simple, no atypia. That is the dosage.
Next, Dr. Chandrika says, ma'am, 37-year-old with 85 only one cycle of heavy bleeding. Does she need endometrial sample for HPE?
Did you say 85? That's
5
important.
mm.
5, just 5. ET of 5 mm. Look, that depends. If you took that scan immediately after her period, it's going to be 5. Yeah, however big it, however thick it was before, if after she's completely bled and you did a scan and it is 5, how can you assume that it has always been 5 or something? So this is a woman you need to scan premenstrually. Give her 2 more weeks and rescan and see if it's more than 12. In a woman, in a younger woman, you can go up to 16 without needing to take a biopsy. But if she's bleeding so much and it's more than 12, that's an indication to take a biopsy. So don't just go by one scan. It's not a number. We're not machines to say less than 12, I'll keep quiet, more than 12, I'll take a biopsy. When was the scan done? How soon after a heavy bleed was it done? So if this woman bled a lot, but then the endometrium is 5, then something happened there. All the bleeding, all the endometrium came out. So rescan her 2 to 2.5 weeks later and see what the endometrium is. If it's less than 12, you don't need to take a biopsy. If it's more than 12, then please do take a biopsy.
Doctor's taking in the last 2 questions for tonight. Next is from Dr. Sheikh. Does a woman menstruate with Minera?
No, she doesn't. She's not supposed to, because a Mirena is supposed to completely suppress the endometrium. However, some people do get spotting once in a while.
And another question from Dr. Swami is, ma'am, what would be the predisposing factors in young women in urban areas?
Obesity, PCOD, diabetes, the routine.
Ma'am, with that, I think we've covered most of the questions. And with that, also, I'd like to mention that there's a lot of appreciative comments for your session in the comment box. I would love for you to take a look at your convenience. Thank you once again, ma'am, for this wonderful session, and thank you for taking in so many doubts from our doctors very patiently. It was lovely having you, ma'am, and we'd really love to hope to see more of you on Netflix. Thank you so much, ma'am, for this
Sure.
session. Thank you
I
once
love
again.
being here. Thank you, Varsha, and thank you all.
Thank
Thank you
you.
all, doctors.
Thank you, doctors.